Salivation, xerostomia is mandatory. You cannot, even if you give the best of the best radiation therapy, IMRT, IGRT, whatever, xerostomia is a part and parcel. Xerostomia vanda caries definitely varudhu. So patients enna adana 6 weeks no they are, that is a big ordeal for them to finish the therapy. So in between coming to us, sometimes they might not do also. So make sure that you call the patient, appave start aara mari the caries ella appave fill panni mudichiteenga, it won't progress. Okay, so that part of the treatment that we need to give. And of course beforehand extract the tooth which has very poor prognosis. Make sure that you have some rapport with your radiation oncologist or the cancer center which is across you, so that all patients may referral can come to you so that you can take care. Okay, it is
the rapport with radiation
oncologist.
The onco teams oda dental இது வந்து
நல்லா
இல்ல ரொம்ப access ரொம்ப கம்மியா இருந்துச்சு.
அதெல்லாம் hospital will take care of all that. நமக்கு போய் சொல்லவே மாட்டாங்க. Hospital itself will do all this what you say.
So, but what happens is that see, in the patient உங்ககிட்ட வராம சார் நேரா ஹாஸ்பிடல் போயிருந்தாங்கன்னா it's fine, accepted. Patient first நீங்க தான் diagnose பண்ணி சஸ்பெக்ட் பண்ணி நீங்க ஒருத்தர்கிட்ட அனுப்பிச்சிட்டீங்கன்னா it's your patient only. You have all the right to call the patient to see what is happening. Sometimes pre-RT அதாவது ரேடியேஷன் தெரப்பி ஆரம்பிக்கிறதுக்கு முன்னாடி எல்லாம் செக் பண்ணிடுவாங்க. And once it started, in between therapy nobody sees, including ourselves, because patient doesn't come to us, we don't go behind them. So in between பார்க்க மாட்டேங்கிறாங்க. In between பார்த்தோம்னா நிறைய ரேடியேஷன் caries and நிறைய extractions can be avoided. அது in between இல்ல, ஒரு till 1 month post radiation therapy you need to see the patient. Okay, I have a good access because my husband is a radiation oncologist. So அதனால most of the patients come to me அப்படியே சுத்தி அதனால I make sure that whatever best care I can give I try to do. So that is one advantage that I have. But நமக்கு நம்ம patient நம்ம எங்க ரெஃபர் பண்ணோம், definitely we can always have the access to that. Okay, so clinical scenario is over. So we'll start again with the dosage again. Analgesic. So antibiotics are better actually modella what we give is only a painkiller because patient invariably comes with pain. So either treatment பண்றதுக்கு முன்னாடி what we give is a painkiller. Okay, so commonly used analgesics. Sir, ibuprofen, aceclofenac. Anything else apart from ibuprofen, aceclofenac? Paracetamol. Yes. Ketorol, yeah. Ketorolac. Anything else? Tramadol, yeah. Anything else? Same. So ibuprofen, commonest, most common, most preferred analgesic. Amoxicillin mari, ibuprofen is also very commonly used one. Diclofenac, nobody uses diclofenac.
No, they come down.
For in our college, a free tablet is diclofenac.
Yes, I know.
So we give diclofenac.
Nobody is promoting itself.
Diclofenac.
Diclofenac, nobody is promoting.
Aceclofenac is now taken over.
Once aceclofenac has come, this is gone.
Aceclofenac is taken over enormously. Dental mattu illa. You go to some orthopedician, also he gives aceclofenac, signoflam, common. Aceclofenac and paracetamol, serratiopeptidase combination. Xerodol, SP, signoflam, idella. Left and right, anybody who, even the medical professionals, they prefer only aceclofenac.
Brufen is gone.
Brufen also, they don't give. I mean, aceclofenac
The imol, patient cannot afford to give imol. They can afford, everybody aceclofenac.
Aceclofenac proven bone marrow suppression.
அதனால we are not.
But prove பண்ணிக்க மாட்டாங்க bro. Aceclofenac.
Next வந்துச்சுனா they'll stop that.
Consider more safer.
Yeah.
They promote that. Saying that they promote it.
Paracetamol, yeah. Paracetamol universal drug. எல்லாரும் எதுக்கு கொடுத்தாலும் ஏதாவது ப்ராப்ளம் இருந்தா கூட சேஃபா இருக்கணும் அப்படின்னு சொல்லி we can give paracetamol. That's all. Okay. So ibuprofen, the most preferred analgesic actually because it has the highest anti-inflammatory action. Actually, anti-inflammatory பொறுத்த வரைக்கும் ibuprofen is the one. Dosage is 400 mg, usually 3 times daily. 400 3 times, that is 8 hourly you can give. Extended little more, 600 வரைக்கும் கொடுக்கலாம். Again you can give 8 hours. Okay. So maximum dosage that you can give is 2400 mg per day you can give. அதுக்கு மேல எக்ஸீட் பண்ணாதான் it's going to be dangerous. So up to 2400, see that அதுக்கு ஏத்த மாதிரி கொடுங்க. Patientோட pain, what exactly procedure you have done. So அதுக்கு ஏத்த மாதிரி you can schedule it and whatever you want to get. Diclofenac, our college free tablet is diclofenac only. So they give diclofenac 50 mg twice a day. நிறைய cases of allergy comes. We have ourselves seen diclofenac நால erythema multiforme வந்து Steven Johnson syndrome வரைக்கும் இந்த patient has gone into septicemia. So diclofenac is one allergic drug actually. Those said other complications of diclofenac. So I am also a little skeptical in giving diclofenac. Wherever possible, I try to avoid. It's up to you, okay? But diclofenac எதுக்கு prefer பண்ணுவாங்கன்னா இந்த aceclofenac, diclofenac group the TMD pink. The TMJ pink, it works out really well. TMJ, you have trapezitis after you work long hours at clinic or 30 patients, 30 patients in a day. Night 11:30 வரும்போது ட்ரிப்பி சைட்ஸ் இருக்கும். ஸோ அந்த மாதிரிக்கெல்லாம் இது வந்து டைக்ளோஃபெனாக் செம்மையாக கேட்கும். ஓகே, அதனால அந்த டைக்ளோஃபெனாக் ஜெல்லே இருக்குது. ஓவிரான் ஜெல், அதர் திங்ஸ் ஆர் நாட் டாபிக்கல் ஜெல் இஸ் பிகாஸ் இட் ஹாஸ் அ வெரி குட் மசில் ஆன்டி இன்ஃப்ளமேட்டரி ஆக்டிவிட்டி. எஸ்பெஷலி நமக்கு பார்த்தா டிஎம்டிக்கு யூ கேன் கிவ் டைக்ளோஃபெனாக். ஓகே, the next one is naproxen. நம்ம கொடுக்கறதில்ல, பட் if you want a longer lasting pain effect, no, so then naproxen is preferred. But generally we don't give longer lasting. You can give 500 mg twice daily, adult dosage. Okay, and so this is twice daily dosage. And that's why it's given longer action. Adanal because it has an extended action generally. Ketorolac acute pain 10 mg adora dosage. So ketorolac is also a very very common drug. Maximum dosage 40 mg per day you can give. That is 10 mg 4 times daily vekku kudukalam. Severe pain patient irukku na ketorolac is the best one. Monthly add பண்றதுக்கு it takes some time. Ketorolac you can give. In fact, prophylactically before also you can give procedure முன்னாடி you can give, and then you can do the procedure. Patient have a very good pain threshold. So in that acute severe post-operative pain, definitely ketorolac also does well. Okay, of course, aceclofenac has now become part and parcel. That's why we just restrict only to 3 days max. Adho acute pain is we generally prefer ketorolac. Regular we don't give at all. Okay. But generally no, they don't allow it to given for a longer period of time. Ideally 3 days. You can extend to another 1 more day ketorolac. Adukku mela people are not preferring ketorolac basically. This is aceclofenac, the main advantage is because the gastrointestinal tolerability. But this is a new input for me as well. So those who don't tolerate aceclofenac will tolerate ketorolac. Yeah, but fine. But generally we don't allow it to be given on a longer duration. Like this 5-7 days, kuda kudukalam 1 week kuda. But ketorolac we don't prefer for a longer duration. Okay. Again, post-operative pain TMD again this is going to be paracetamol. Okay, so paracetamol, what is the dosage? 500 mg?
500 to
1000 mg. So you see 500 to 1000 mg every 4 to 6 hours. Maximum dosage that you can give is 4 grams per day you can give. 1000 mg tablet ipo varudha 4 times you can give. Safe, absolutely safe. Patient liver disorder, and if you are finding, if you are suspecting or proven case of A, B, C hepatitis anything na, restrict up to 3 grams. Okay, otherwise generally 4 grams you can give. So paracetamol where patients who have severe pain, pregnant patients, 2nd, 3rd trimester, where you cannot give any other analgesics, and if you feel, extend your paracetamol a little more, that will work out well. Okay, so liver disorder, renal disorders, though they say it's hepatotoxic, even for liver it is basically paracetamol, which is the drug of choice. Nothing to beat paracetamol. A peptic ulcer, of course, pregnancy patients also. Okay, so it's probably universal drug where we can give. Has a lot of antipyretic, little bit of analgesic, little bit of anti-inflammatory action. So that's why it is not generally used for severe pain at all. Tramadol, eppod podukalam tramadol? Severe pain. Ellame feel aachna last tramadol. Anything else? Where is CKD, yeah. Pregnancy we don't give, sir. As far as I know, we have not given tramadol. We generally give only paracetamol. We have also given sometimes ibuprofen, but definitely not aceclofenac. NSAID allergy. So tramadol the dosage is generally 50 mg every 6 to 8 hours, 3 days. This is thrice daily. TDS dosage na tramadol. Okay, maximum dosage is generally 400 mg per day in healthy adults. So 400 varaku you can extend. Remember, this over the counter you can't get unless you have a prescription. Prescription illama tramadol kudukka maattam. Kudukranga? Oh, easy adala kedukranga easy oh, நான் வந்து ஒரு பேஷண்ட் ஃபோன்ல just gave இது கொடுக்க மாட்டேங்கறாங்க மேம் ஒரு prescription
நம்ம பிராண்டட் pharmacy அந்த மாதிரி இதோட இருக்கும். பட் ஆனா ரெகுலர் நிறைய pharmacies
correct. So allergic NSAIDs, renal patients, severe pain, renal patients ku the drug of choice. Suspected creatinine konja high irukku, kidney dialysis patient ellathme tramadol kudukalam. Common drug what is given is combination of tramadol and paracetamol. Ultracet. And ultracet la dosage ebbu theriyuma sir tramadol?
tramadol 37.5.
50 mg the actual dosage. Ana ultracet la 37.5 da irukku. Adhe mari paracetamol 325 da irukku. It is actually lesser dosage in ultracet.
Acecloparaline அப்படிதான் 100 plus 325.
100 தான் aceclofenac
இல்ல
dosage.
paracetamol treatment.
Paracetamol dosage. If that one kidney is functioning well, nothing to worry at all. Normal, yeah. It's absolutely fine, no issues at all. If you have still doubt அப்படினா ஒரு RFT பண்ணிடுங்க. Renal function test பண்ணிடுங்க. Creatinine levelum is fine அப்படினா, urea creatinine is fine na, no worries at all. Regular dosage of antibiotic can get it. No issues. Okay. So whenever you have any doubt, make sure that you do the parameters. Liver na LFT பண்ணிடுங்க. LFT ஓட சேர்த்து hepatitis B titerum பாத்துடுங்க, antibody titerum. So all that is important. So again, if you have a renal patient, make sure that you take a renal function test. And if everything is normal, you can go with your regular dosing. It's not a problem. So now there's an era of combination drugs. Okay. So combination drugs pogalama better. Yes or no? Yes sir. Pogalama.
அந்த பழம்
Even government education.
அதெல்லாம் இருக்கு.
Mainly for all trigeminal urine.
So the neurology I'm not dealt with sir. ரொம்ப rare தான் purpose.
Focus more on antiplatelet and anticoagulants. Most of the patients now come with some combinations, and we don't know that which combination they are having. Is it better to go for a bleeding type combination?
Sir, coronary artery disease, CAD patient on regular medication, illa diabetic hypertension, preventive aspirin clopidogrel of combination statins ella kodutundanga, better to take a PT, PTT and INR sir. PT, CT evada kuda better to take an INR. It's better sir. Even if you tell patients, nobody will object also, because it is for their good that we are going to do. Adanal sollittu pandrathu is always better if you have a doubt. Nowadays there are a lot of new drugs coming. Munnadi namakku therinjadhu the clopidogrel aspirin. You don't know names like combination. Adukku thaniyave we have to do one seminar sir.
Maybe we Google it actually. Maybe whatever drug comes now, nowadays we Google it and see what.
We have to Google it. And the mari actually and the name le therinja no statin irukum. Some kind of some clue irukum sir actually. ஒரு 10 drug la ஒரு drug ஏதோ doubt இருக்கும். அந்த ஒன்னு ரெண்டு மட்டும் Google பண்ணி பார்த்தலாம். Matadana we usually know, but it is humanly impossible to bring all those newer drugs into this because ellame has different brand names also sir. And all depends on the particular rep and the cardiologist kita pona and the particular brand. So நம்ம வந்து it's very being in leave alone clinic sir. Ramchandrale ஒரு எக்கச்சக்க brand வருது sir. At least ஒரே தடவை சார் சுத்தணும் அதுக்குள்ள actually there's so many things that
இருந்தா போதும். இப்ப நீங்க சொன்னீங்கல PT PTT அந்த flow chart இருந்தா it will do better.
Yeah, PT, PTT எல்லா coronary artery patients க்கு போட்டுடுங்க. அதே மாதிரி if you have patients on dialysis on aspirin clopidogrel போட்டுடுங்க. INR பண்ணிட்டு manage பண்றது is always better. And it is easy to send for a fitness. அதுதான் நம்ம usually எழுதி கொடுத்துறது. But கொஞ்சம் rational think பண்ணி add on some investigations which you think is necessary for yourself, add on that and send also. Along with fitness you get this investigation report also. Then you write royally you are absolutely safe. That's what that we gently prescribe. So combination drugs la we have ibuprofen, paracetamol, we have so many combination drugs are there, okay? And what are the advantages, pros of combination drugs? ஒரு 8 tablet முடிஞ்சு multiple 10 tablets சாப்பிடுறதுக்குள்ள ஒரு 5 tablet is okay we know for us, yeah. Anything else? Cost wise cheaper. தனியா ஒரு டேப்லெட்டா வாங்குறதுக்கு எல்லாம் சேர்த்து வாங்கிட்டோம்னா கொஞ்சம் சீப்பராவும் முடிஞ்சிடும். இல்ல actually sir, actually combination drugs are more costly.
Number of drugs increase ஆகிட்டு patient becomes
more frustrating.
இவ்வளவு மாத்திரை எடுக்கணுமா அப்படின்னு
லைஃப்ல மாத்திரை.
Ibuprofen மட்டும் கொடுக்குது, ibuprofenoட paracetamol சேர்ந்து கொடுத்தா pain control is much better. That's what they say. Compliance is better. Synergistic effect. One shot giving ibuprofen 400 தனியா paracetamol இன்னொரு 500 அது 4 times எடுங்கன்னு சொன்னா patients generally are அதே ஐ மோல கொடுத்து இல்ல காம்பிஃப்ளமா கொடுத்துட்டு 3 times எடுத்துக்கோங்கன்னு சொன்னாங்கன்னா they are all happy. So all this cons is basically fixed doses. Suppose நம்ம ஆல்டரேட் பண்ணலாம் அப்படினா we cannot do because ஒவ்வொரு ட்ரக்குக்கும் I've said no you have a maximum dose up to which you can titrate to. So and the titration cannot happen if you're going to mix. ஒரு ட்ரக்கு மட்டும் ஜாஸ்தி கொஞ்சம் கொடுக்கலாம்னா அது முடியாது, அது ஒரு ப்ராப்ளம். Cost is higher, adverse effects are more. Okay, so தேவையில்லாம you can have some additional adverse effects also. And irrational prescription. Sometimes இன்னும் கூட the combination of this aceclofenac, serratiopeptidase, paracetamol is still not justified anywhere. And the மூணு சேர்ந்து ஒரு signoflam ஒரு zerodol SP வருதுல சார், அது இன்னும் கூட வந்து அது எதனால அந்த காம்பினேஷன் it's still it's not evidence based basically, okay? But for our convenience base, we are just doing it. So that's about it. So then we come to this. Serratiopeptidase, chymotrypsin, trypsin. Common and pair and the drug pair. Controversial. Kudunga, kudukka mattenga. Xerodol experience serratiopeptidase. Chymotrypsin. Common. Kudu or chymotrypsin போட்டா கம்மி ஆயிடும் அப்படின்ற பெயின் கம்மி ஆகும். So yeah, swelling. Yeah. Basically, this is a proteolytic enzyme. So the main mechanism what they say is edema correct. That is சுத்தி இருக்கிற அந்த and the swelling, no, it brings out. So probably we can say as an adjunctive anti-edema therapy. That's all that it is basically claiming to. Okay, and thrice daily that we are going to give. And serratiopeptidase 10 milligrams thrice daily.
For abscess cases.
See, generally, no, there are two versions in this. But swelling இருக்கும்போது what they say is the proteolytic enzyme. It lyses it. Spread of the infection ஜாஸ்தியா இருக்கு. அதாவது ஒரு ஸ்பேஸ்ல இருக்கிறது செல்லுலைட்டிஸா மாற்றத்துக்கான சான்சஸும் இருக்கு. அதுதான் மேஜரா, that is why the people are skeptical, especially giving abscess. But எப்போ கொடுக்குறாங்கன்னா mostly the post infection and the transalveolar extractions they give. Why they say is that and the edema and the post inflammation it will bring down. So you feel that it is the infection is not there, it's only the healing part that you are going to promote to, then you can probably add on the chymotrypsin or serratiopeptidase. But if there is an active infection, you have to be very very careful in giving. அதாவது abscess பெருசா இருக்கும், அப்போ ஒரு அமாக்ஸியும் கூட ஒரு சிக்னோஃப்ளாம் Xerodol சேர்த்து போடுவாங்க. Be little very careful because there's a chances that it might bloom also. So be very rational. Most of the times when they are giving this, only post the AIDS extraction. Okay, you think it's a very major extraction, a lot of traumatic extraction they give. Otherwise, infection இருக்கும்போது be very very careful. And there's no evidence. இன்னுமே the CPG clinical practice guidelines evidence based it is still not come. Most of the others எல்லாம் கொஞ்சம் அங்கங்க somebody is doing something, but இதுக்கு இன்னும் it is still not evidence based. So then be rational in giving a prescription with NSA. Combine தனியா NSAIDs கொடுங்க, அதுக்கு அப்புறமாவும் inflammation edema குறையல, you think you can add on a chymotrypsin, you can do. One more thing what I have seen is in the after cells எல்லாம் வரும்போது sometimes some bigger ulcers and all சுத்தி செம்ம edema இருக்கும். Sometimes there will be a lot of ஒரு swelling மாதிரி இருக்கும், அந்த ulcer சுத்தி ஒரு சின்ன edematous இருக்கும். Put chymotrypsin, நல்லா கேட்கும், it will bring down actually. Okay, and the pain factor will come down, that it will shrink, and then 1 week or 2-3 days earlier it will also heal. So in that cases if you can give, but infection இருக்கும்போது active infection போது you can just think through and then you can add on. Okay, so next few more drugs major where I am not going to go into sir government ella sonara neurangina I am not good because it's too much. Iduve I have exceeded anything. So okay sir, I can continue.
Yes sir.
No, half an hour letting me go. So case scenario, okay. So this is common like. What could be this? ரொம்ப பார்த்துட்டோம் இப்போதான் I was also telling recurrence, yeah, afters. Okay, so nowadays we see very commonly, even in students, younger individuals also, afters also very very common. Okay, so it's afters minor, but you can have two more. Okay, right now we are treating even in our college afters major. Where is our it's a big huge ulcer, it's not shrinking at all actually. Afters major, then you can have sometimes even this is called as herpetiform type. Kutti kuttiya irukku ulcers, this is herpetiform type of afters. Okay, so when you have an afters major, if it's a big ulcer, reluctant to heal, 2 weeks ku mele heal agama irukku, but the ulcer I mean afters are not the CA or anything like that abina, definitely put them on a HIV test. Check for HIV for ELISA 1 and 2, easiest adha western blot alla confirmatory. HIV 1 and 2 for ELISA pota we will know whether they are positive or not. He turned out to be positive, that guy. Okay, so and in the idella heal agumbodhu scar agum or sometimes pigment agum. Pigmentation is one another common condition why people come to you. முதல்ல வாய் இப்படி இல்லை, இப்போ கருப்பா இருக்கு அப்படின்றது ரொம்ப காமன். So whenever you have pigmentation, first thing is ask about drugs. Any oral contraceptives, any anti-malarial, lot of drugs cause pigmentation. So try to get the drug history. இன்னொன்று just like நம்ம vitamin D deficiency சொன்ன மாதிரி பாதி women are anemic. அந்த hemoglobin 10க்கு மேலே இருந்தால் பெரிய விஷயம் அது இப்போலாம். So முக்கால்வாசி anemic, chronic anemic patients, so there will be a lot of pigmentation. So it will be related to your anemic status and the pigmentation. Then yeah, you in multiple other conditions also you get pigmentation basically, but pigmentation ne ஒரு complaint வர patient இருக்காங்க. So just think through, get the history, ஏதாவது ஒரு correlation இருக்கும். So then you can just help out. But remember this, all these afters major, lichen planus, all these chronic infections and all, chronic lesions and all, basically heal with pigmentation. Pigmentation is a sign that it is healing basically. Okay, so just make the patient aware that இது வரும் அப்படினு. அவங்க இது போயிச்சு அது வந்துச்சுன்னு சொல்றதுக்கு முன்னாடி better you tell them that. Herpetiform after, remember that you have to differentiate from herpes. Okay, because treatment is மாறும். Herpes அதே மாதிரி இருக்கும். Intraoral herpes, primary herpetic gingivitis. Also it has small ulcers like that only. Okay, but the treatment will differ. How it will differ? இங்க நம்ம என்ன கொடுப்போம் aftersக்கு? Aftersக்கு what do we give, sir? Local act பண்ற anesthetic. What anesthetic we give, ma'am? Generally aftersக்கு. Topical, ma'am. Topical. In a what is steroid, ma'am? Steroid வேண்டாமே ma'am. Mucopain gel, lignocaine gel, mucopain is benzocaine இருக்கு. இதான் காமனா we give generally, okay? So that is for an anesthetic effect. But if it's going to be in herpetic gingivitis, pure herpes ulcer, you have to start them on an antiviral. So it's completely different because அது heal ஆகாது நீங்க just anesthetic மட்டும் கொடுத்தா. So then definitely the treatment regimen will differ. So make sure that you ask for prodromal. எங்கயாவது ஒரு இடத்துல ஒரு மைல்டா ஒரு ஃபீவரோ பாடி பெயினோ something would have happened. So and the history of can be just over 2 days back, 3 days back, that itself will give a clue that probably it is not herpetic aphthous, but it's herpetic gingivitis. Okay, so every viral infection will have a prodromal. Number 1. Number 2, இப்போ off late நிறைய herpangina I'm seeing. Herpangina is basically ulcers in the uvula, throat and soft palate, and that's caused by Coxsackie virus. That's another virus basically, and that's called as a summer's disease. இப்போ நான் ஒரு 5 பேருக்கு நான் இது prescription எழுதி கொடுத்தேன். Severe throat pain, fever 2 நாள் முன்னாடி பார்த்தா வாய் frontal ulcer இல்ல, only the throat full ulcers basically. Okay, it is not in the ENT or the division, it's our part only. Okay, so then we give our own treatment, antiviral, and then the treatment, then it goes off. It takes its own sweet time, 7 to 14 days ago, but that's called as herpangina. So that's also one viral infection, and that we need to differentiate from any aphthous or anything like that. Treatment generally anesthetics கொடுப்போம், vitamin supplements by and large கொடுத்துருவோம் இல்லையா generally. அது by default ஒரு 2 வாரம் vitamin supplements சாப்பிடுங்க. பட் ஞாபகம் வச்சுக்கோங்க, டங்க்ல வந்துச்சா zinc supplements கொடுங்க. Zinc is always good for tongue. Anything with tongue. Tongue டேஸ்ட் சரியில்லை, ரொம்ப சால்ட்டிஷா இருக்கு, whatever they say, zinc sulfate tablet you can give. இல்லையா combine the zincovit which has everything along with zinc. கொடுத்துடுங்க. 1 monthக்கு the patient actually recovers well. tongue related issues. இந்த மாதிரி பெரிய பெரிய ulcers, multiple ulcers, tetracycline mouthwash does well. இதை பண்ணுறதுக்கு கஷ்டம் பேஷண்ட்க்குன்னா யூ ஹேவ் அ ரெடிமேட் மவுத் வாஷ் கால்ட் லிடோகேம் மவுத் வாஷ். லிடோகேமில் ஒரு ஆன்டிபாக்டீரியல் ஏஜென்ட் இருக்குது, லிக்னோகைனும் இருக்குது. ஓகே, லிடோகேம் இட் இஸ் கால்ட், LIDOCAM, not available everywhere but few pharmacies you get. So that is also an antibacterial mouthwash basically, per se antibacterial, which will shrink these secondary bacterial infections. Okay, and then sucralfate syrup. Sorry sir, tantum is benzodiazepine sir, அது anti-inflammatory தான். So inflammation it will bring down definitely in allergy and infection. Yeah, but this lidocam has a dual action. Lignocaine irukku, antibacterial action irukku. Sucralfate syrup இந்த முக்கால்வாசி வர aphthous ulcers எல்லாம் இந்த காலைல வந்து பிரேக்ஃபாஸ்ட் சாப்பிடாதவங்க, excessive stress ஆயிட்டு exam time, so all these stress factors are the ones which causes this reflex GRE and all. Put them சும்மா ஒரு additional ஒரு 1 week sucralfate syrup கொடுங்க. 1 minute mouthல வெச்சிட்டு that will coat the ulcer, then they have to take it inside. That will coat the entire gut also. Dual way it will work out very well. சும்மா ஆட் ஆனா கொடுங்க, இதனால ஒன்றும் ஆக போகுது. There is no side effects for sucralfate also. Just add sucralfate syrup, you take it, okay? And still you feel that ரொம்ப recurrence வருது, it is keeping coming again and again அப்படின்னா get a medical gastroenterology opinion. Have one person whom you know adjacent so that he can also help you. அவரோட கேசஸ் உங்களுக்கு ரெஃபர் பண்ணுவாங்க. அந்த மாதிரி ஒரு rapport you try to build up with some gastroenterologist who's there. Okay. Recurrent ulcers, thorough history, hemogram பார்த்துடுங்க.